Good morning. This is Dr. Bill Wyatt with the American Orthodontic Society, and I want to talk to you this morning a little bit about impacted lower laterals. And in this particular case, she also had some upper cuspids that were erupting into the roots of the developing laterals, and we'll go through that. They had huge follicles on them, but primarily I wanted to discuss these impacted lower laterals. So we'll get right on with the case here and get showing it, and try to be as take as little time as possible. This is a beautiful young lady here, and she's got just a perfect facial structure. The cephalometrically and everything's great. And when you look at her models, you can see the cuspids have kind of gotten ahead of the laterals in erupting in, and that's the only reason I can see. I've had a number of these impacted laterals over the years, and learned how to deal with them pretty early. So you have to get into the case before you would normally go. And this is another reason that pediatric dentists should be able to do these things and not feel like they're impinging on the orthodontist. So anyway, let's get into this. Both sides of it, the cuspids are a little bit ahead of time, and I think the lateral erupts and hits this cuspid and deflects it lingually. The ones I've seen, the impacted lateral would be coming out back toward the tongue quite a bit. I'll show you that on these models here in just a second. You can see the lateral right there. I mean, it's coming in back in this area, and this lateral is coming in right here. And you can look at the models right quick and see that this permanent cuspid is moved ahead of itself and gotten in underneath there, and seems to force the lateral to erupt lingually. The ones I've seen, nearly all of them would be on the lingual side back in here. So let's get into this a little further, and I'm going to erase that, and we'll go to the surgical part. We took you could see what was developing, so there's no reason to sit around and wait till the thing comes in way back in here. I've gotten them sometimes it would come in with a lateral way back in the lingual side. So we took electrosurge. You can see how this is cut right in here, and it's cauterized and everything, and came on up and uncovered this cuspid right in this area. So we're going to pull this lateral in this way and push this cuspid back in this part over there, which is just plain common sense, and you've got to open the whole space even more than that to do that. So now the other side, we trimmed down inside and then made room enough. After you do the electrosurge, they don't bleed much. It cauterizes the tissue too, and sometimes you'll run into other teeth, and sometimes you hit something metal. They will really let you know. So we have to take that tissue off carefully and try not to even run into other teeth, but you will hit them like this. You can't come to an area like that without peeling the tissue off of that. But this cauterized tissue doesn't bleed much, and I'm not going to say it doesn't bleed, but it will not bleed like it normally would. So you can dry this off and etch it and I put the laterals brackets on those teeth at that position. I didn't clean the bonding material off much here, just put it on there and was glad to get it on there before it got moisture back on it. So anyway, those teeth are bracketed. That's a problem you'll have in bracketing the teeth like that. Now we look at, I've got about I think 5 or 6 x-rays here showing you this development, and this is 1982, and that's quite a ways before we don't start the case till we get most of the permanent teeth in. Now you can see this cuspid coming in like this, and it kind of went under the lateral, and it's got it forced back in this direction. This cuspid hasn't got in over here yet, and it'll come on up in, and it's going to shove this lateral way off. This is a little earlier than those pictures back there I showed you. And now the upper cuspids are coming in, and they've got these huge follicles on them. That's not normal. That cuspid should be coming in right underneath the deciduous cuspid, which is here, and once it breaks the actual follicle is penetrated, the liquid goes out of it, and this cuspid will come on in like that. But it's late coming in, and you can see the cuspids are having some effect on the root structure of the permanent lateral right in here. And you'll see these laterals, after we finish, will have some deterioration in the tips of their roots. And so, well, I'll draw this one. It comes in something like that. Now that's unusually big. This is a more normal follicle around a developing tooth right here, see? And it's just a little ring around it, and it's filled with liquid. And so we'll have to do away with that now, and let me show you the next Panorex that we took. This was the first one, and all this is laid out in there. Now you can see the wisdom teeth developing, the second molars. You can hardly see a wisdom tooth up here, but there was forming, and all the wisdom teeth are in, and they're going to give us they're going to be impacted and there's not near room enough for them to come through. So let me erase that again. Now this is in 1983, and we've already started this case. And we started it actually before we got most of the permanent teeth out, but we still have a few permanent teeth in there. So sometimes you start when you need to, and you may have to I've seen these cases that needed 2-phase treatment, that we would go in and never find a place to get out. So you'd have to stay in there from, say, for 4 or 5 years, before you was able to finish the case. And it seems like people coming out of the schools haven't really carried a case like that for 4, 5, or 6 years before they could finish it. They have to pick up one that somebody else has started, so they don't get the full meaning of it. That's just my thinking, and I know some of these guys coming out of school put them together quite good and know what to do in that, but I've talked to the pediatric dentists that say there's 2 or 3 pediatric dentists have a big clinic, and they hire an orthodontist to come in, and most of them tell me that the orthodontist doesn't know anything about, or not very much about, preventive and interceptive orthodontics. And this is why I think that pediatric dentists ought to know it and do it, or if they can, hire somebody to come in and do that so they can do these little things along the way. You can't sit around and wait till they're 12 or 14 years old before you start, because the damage is already done. So I feel it's necessary that pediatric dentists do a certain amount of orthodontics, and anybody that works on kids ought to be able to do some of this orthodontic work. Now the follicles are still in there. This is 83. They're still pretty good size in here, and this is the permanent lateral root. And if I'd have been on the ball good enough, I should have put a little tip in this burr in here and brought this root over in this direction, and it would entice this tooth to come down there. See, if I'd put the tip in there, just a slight bit of tip right here, it would have moved this root over here, and that's best what should be done. And I may have lost part of the roots of the tips of the roots on these teeth, but they came out pretty good anyway. But maybe if you see that, you can kind of bunch the roots together, see, and that opens up the space for the cuspid to come down. Once it gets down past there, then you can turn it loose or go back over and take that tip out of the wire, and it'll put the root back in the ideal place for it to be. So let's move on. This is 1983, and we've gotten these laterals lined up. I mean, they're okay now. All right, let's go. And this is 9 of 83, which I believe is about 6 months later, and we've got this cuspid coming down real good now, and it's got a spring opening the gap right here for it. And this lateral root is just damaged to some extent, and this one will be too. And we'll open this, and I really wish I had put this tip. You know, you just go up, you come along with the arch wire, and you can be in a little flexible wire and put tip in, and it'll put those roots over so that they don't get this damage that you see there. Now we're going to go back to Panorex number 4, and you see the root is slightly damaged right in here, and this cuspid is slow coming through, and we've taken these out, lined these up, and I'm opening the gap wider than we need. When we get the tooth into the gap, we will close back up around it. This came out beautiful case, but it could have been better. You got the lateral roots look pretty good as we go down to the next x-ray, and you see this lower wisdom tooth has run into this, and it can't go up. Well, there's not near enough room in the jaw for that tooth, so we're going to have to somewhere down the line. But I didn't have any Panorexes where we took the wisdom teeth out. This is I think number 5's end of the Panorexes. So that's 2 of 84, and that's about a couple of years we've been in here. And here we're in for another year. This is 85, finishing this up. Now everything is in, and this is not a real good Panorex, but there's some blooding of the roots of these 2 laterals. Not serious, but could have been less if we'd have just put that lateral root over a little, which you can do with fixed braces. And you really can't do that kind of orthodontics with these plastic shells going on there. I don't know how in the world you take a case young like this and do these things in preventive orthodontics and bring their teeth in without having something fixed on the teeth themselves. Now let's go on to and see what happens. Now here we are weighing the case, and this is the 1984 again. And this is going back, and this is how we did this in put the brackets on the teeth. I could have used a little narrow brackets up there, which I like best, but you can use double brackets in the front like here, but down on the bottom we use a little small brackets, but they've got these wings on them that help you rotate them, but it doesn't take anything away from the inner bracket space down on those teeth. So I use those quite frequently in doing this. Now we open the gap for the cuspids wider than it needs to be, and when the cuspid gets in there, you see we've got these pushed back further than we want over here. And when the cuspid gets in there, we'll come back and close those up, and we'll be in a heavier wire. Okay, here's the we've opened the gap really big for the cuspids, and when they get in, we'll come in and close that up. So I'm going to show the next video, the next Panorex here, and you can see we've got both cuspid and the bicuspids in that space. Now we'll just start closing our arch wire and tightening it up. You can see we got this omega right here, and we're tying this back, and you can close during any space you want to, unless you got a ankylosed teeth in there somewhere. Now that space, just by tightening the arch wire up right here, and every time they come in you tighten that, and if your omega runs into the molar, come out here and make a little deal like that, just a little U drop down in your arch wire, and something like that, and you put it, you got to have the same on both sides and everything. That'll pull the omega forward and allow you to close some more. And so we don't have to change arch. We take it out and make those little bends. You just mark where they want to go in, and that keeps the center of this in the same place. And that's one thing you want to always do. And on the lower arch, you just virtually always band or put brackets on it or something, whereas the upper second molar frequently will drop in on top of it if it's correct on the bottom, and you won't have to band or bracket the upper second molar as often. Alright, let's go to the next one. Now this is not, this is blurred a little bit, but you can see where the teeth are. The midline's right dead center, and the cuspids are going into place, and we've closed most of this space up. And I'm going to go to the next Panorex, which is 9 of 85, and so we're taking a lot of time finishing this case out. But now the teeth are in there. The cuspid, the lower cuspids have those little small brackets on them with the wings. The upper cuspid, we still put a narrow bracket on that also. So let's go on to the next one. The same thing on the other side. It's coming in good. And here is the upper, just looking straight at the upper. That we don't have the upper second molars banded or bracketed, and they're kind of falling in place on top of the lower, and we've still got a little bit of space in there. But let me see, I jumped ahead, and down on the bottom, it's we've got all the space closed up on the bottom now. Now, if you remember how it looked, and those cuspids were way over here, and this lateral was way back there, and this just couldn't have come in correct. It would be a mess. And then once they get grown and all these teeth have shifted forward, or get to 12 or 14, or maybe 15 or so, your case is already messed up, and it's be very difficult to get it back and do it as good as you could on the way. So lots of this orthodontic stuff is done in little increments while the teeth are developing. And I always remember my grandmother saying, a stitch in time saves 9. And that's certainly true in orthodontics. Going in there early and doing little things at different points. Now you're in the case for a long time, but a lot of it, that time you're not doing anything much to it. You just keep them brushing good and see them back not so often. And when you need to do something, you go in and do it and prevent something worse from happening. All right, here's the next one, and here we are in 1986. I've finished the case, but I used to leave these 6 on down here until I got a 3-to-3 bonded on the back. But I don't do that I haven't done that anymore. So we got to where we bonded those while we still had the arch wire in place and everything. We would come in and bond our 3-to-3 on the lower anteriors. Now, looking at it from the side, we got it in a real good class 1 relation, both sides here. And here's the upper arch in January of 86. And the lower arch is here, and I think I don't know whether I've got anything with the bonded deal on it. Here's 86 Noah, and this is the finished case. And so we put a retainer in there with a bite plate on it, and the lower teeth make this indentation. We build a retainer, put some soft acrylic on here, put it in the mouth, and then have them get to a good resting position of the head, and then close their teeth into that. If you lean your head back, your teeth will go back. If you lean it forward, your lower teeth come forward. So you got to get where they're going to be, and you let them bite together in that point, and we leave this bite plate in nearly all the cases. Now we had them banded, so we put this retainer in, and then you've got to trim a little right in here on these teeth, and then it will allow you to move, the teeth will move forward, or you just close it up here. And so we've trimmed this just a little right in this area, and that lets the teeth come forward, or you tighten your retainer and it'll move them forward as it comes in there. So this is really the end of the case, I think. And here's the young lady after she got a little older here. Then this is a ideal, and it was good when we started, and it's still good. The vertical height of the face and everything is good, and the percentage, in here is a little bit more lengthened down to the bottom, but this is good, and the young lady's face is going to be good, and she's got a beautiful smile. And this will be with her if she will cooperate and use that retainer properly, and finally end up sleeping in it and using it. And so this really sets up. Now she's going to have to get the wisdom teeth out, and you make sure they do that. Really, I like to get that done. If it's a few years later, I keep watching the people in retention for a year or so after well, we watch it always for a year without any charge. Just want to get them back and make sure that everything is working right. And so I think that finishes up our case, and I appreciate your watching, and I hope you get something out of this. I've got so many of these videos now. I talked to a fella on the phone the other day, and he was asking me about a case. I said, well, that's in the video back there. He said, well, you got so darn many of them, I can't hunt for it in there. I wish we had a way you could punch in and find them alphabetically, something. We'll try to do something like that. But anyway, that's the end of this. Thanks for watching. I hope you join our group and subscribe to our channel here. So thank you, and I'm going to say goodbye, and we'll stop this case. Let me see if I can get this deal over and stop it.